Good morning. Thank you so much for having me, for that introduction, and especially for your stories, Rebecca and Kristen. Let me see, got my slides back there. I probably have too many considering, but we'll work together as far as the slide advancement goes. And I will tell you that this type of presentation over the last few years has really evolved for me. I used to have two very different talks. I had a talk for healthcare providers where I'd get into genetics in depth. I'd talk about different conditions where we can see breast cancer. And then I had a completely different presentation I would do for people in the community. And over the years, the little bits of genetics I would get into the community, that's what people were really interested in. They'd come up and say, that was so interesting. I hated biology in school, but that made me want to go back to school again. Can I ask you some more questions about genes? Can I ask you some more questions about conditions? So now the two presentations have become much more similar, and you're probably going to feel like I'm taking you back to high school biology this morning. But I promise it will be far less painful. So just a few things I'm going to touch on today. First, there's a few different categories of cancer. So I'm going to talk about those. I'm going to go over hereditary breast and ovarian cancer associated with the BRCA1 and BRCA2 genes, because that's usually what people have the most questions about, and it's the most common genetic condition that increases the risk of breast cancer. But I will touch on a few other conditions, most of which you probably haven't heard of, but again, that's what people have really been interested in and have asked the most questions about. I'm going to talk about the pros and cons of multi-gene panels. Genetic testing has changed a lot in even the last few years. So I have several patients that I saw in 2012, and they're coming back again now because things have changed so quickly. And they just want answers. They want to know why they developed breast cancer. So when they hear that we're offering maybe a test with 21 genes, whereas they got a test for 2 genes back in 2012, they just want to know what's out there. And so we sit down for 45 minutes, an hour, and talk about those pros and cons. And that takes us to just exploring what genetic counseling is. A lot of people haven't heard of it. And the first question I always ask patients is, what were you told about what we'd be talking about today? And usually they say, really, I'm not quite sure. And unless you've been referred to a genetic counselor, most people haven't heard of us. So I just want to talk a little bit about what we do in case it might be something that some of you would find helpful. So to talk about the different categories of cancer. Only 5 to 10% of breast cancers are due to a single underlying genetic condition that's being passed from one generation to the next. So that's definitely the smallest category. That's the category I work with the most. There's another 20 to 30% of breast cancers that we call familial. That means we see more breast cancer in a family than we would expect by chance, but there's not one single underlying genetic condition causing it. So we think there has to be a combination of different genes and environmental factors working together. And one thing you could think about is, diabetes or heart disease. Those are things you can see clustering in a family where we know maybe you're at increased risk if you're in that family, but at the same time there's some environmental impact too. So that's sort of a parallel example that you can think about. And certainly in that case, though, there's not going to be a genetic test to give us an answer. We can still follow women in those families differently. So even if you go through genetic counseling and genetic testing is not appropriate or doesn't give us an answer, there may still be a customized plan that we can give other women in your family. So sporadic cancer is the most common. Breast cancer just happening by chance. Unfortunately, 1 in 8 women develop breast cancer in their lifetime. So most are going to fall into this sporadic category. But the difference is we usually see these at later ages. So many of you in this room wouldn't fall into this category because already just your age makes us suspicious. But sporadic cancers might happen at later ages. In a larger family, we don't see a lot of other cases of breast cancer. We may see some hormonal risk factors there, and so we think, we're not too suspicious of this being due to an underlying genetic cause, and most likely the women in this family don't even need to be followed any differently than general population guidelines like starting mammograms at 40. Next slide. Familial cancer I was talking about before as being sort of a combination of genetics and environment. We take these family trees, I probably should have pointed that out sooner. We call them pedigrees, and it just sort of helps us map cancer in a family. So you can see men are squares, women are circles, and it kind of works upward into a family tree. So at the bottom there is one generation and parents and grandparents, and it helps us track cancer through a family. And then we color in anyone that's had cancer so that it's a little bit easier to see. So in this family, we have a few women that had breast cancer in their 60s and 70s, but some of them are even related to each other through other women that haven't had cancer. So really, we may want to make sure these women tell their doctors about the family history of breast cancer, want to make sure they're being vigilant about their breast surveillance, but we're not really going to recommend any genetic testing because it's not quite suspicious enough for us to think that they fall into that 5 to 10% category. Next slide. So when do we think, other than just early cancer, when do we think genetic testing might be appropriate? Now this is really general. We're going to get into some more specific examples in a bit. But cancer at early ages, in general we say that's before the age of 50. If we see multiple people on the same side of the family with the same type of cancer, that's more suspicious to us. There are a few cancers that we know can be related to each other within, one umbrella of a condition. So for instance, breast and ovarian cancer. So if we see that clustering on one side of the family, we're more suspicious. If we see rare cancers like male breast cancer, that's going to make us think perhaps there could be a genetic cause. And then in some cases, an ethnic background could make us more suspicious. So in every ethnic background, there are certain genetic conditions that are more common. And one example we'll get into is, in Ashkenazi Jewish individuals, we can see hereditary breast and ovarian cancer much more often, even though we see that condition across all different ethnic backgrounds. Next slide. So this is the part where I'm going to take you back to high school biology, a part I used to not get into, but it ends up being everyone's favorite. So just to review, our body is made up of millions of cells. All of those cells contain the exact same genetic information, whether it's a breast cell or a blood cell. And that's because that's our body's instructions. That's the instructions that tells our body how to grow and develop and function, what dictates our appearance. We have those genetic instructions our whole life. We're born with them. We have 20, 30,000 genes, and every gene has a very specific job to do. So we have genes that, again, dictate appearance, genes that tell our heart how to function or how to control our respiratory function. And we have a whole class of genes called tumor suppressor genes. These are good genes. These genes protect us from developing cancer. And they do that by telling our cells not to grow and not to divide when they shouldn't, because that's what cancer is. It's cells that have gotten out of hand, cells that have grown too much, too far, gone to places they shouldn't go. So these tumor suppressor genes are constantly trying to keep that in check. But what happens if someone is born with one of those tumor suppressor genes not working like it should? At that point, that person's at increased risk for cancer because their defenses are down. So these tumor suppressor genes are, again, good things that we all have. But if someone's born with what we call a mutation in that tumor suppressor gene, that's when it doesn't work like it should. And all a mutation is a misspelling in a gene. And if we have 20 or 30,000 genes, you have to imagine all of us are probably walking around with mutations in something. It's just that some of us know it and some of us don't. So these good tumor suppressor genes are things like BRCA1 and BRCA2, which we'll get into in a bit. So when we do genetic testing, we're not checking to see if you have these genes. We all have these genes. We're checking to see if they're working like they should, or if we read through them like a spell check, is there a harmful mutation in that gene or a misspelling that would cause it to not work? So we talked about general red flags. When do we offer genetic testing, or when are we suspicious? Now we'll get into a specific condition. Most of you have probably heard of hereditary breast and ovarian cancer, the BRCA1 and 2 genes. Raise your hands. Pretty familiar, especially in this group. Okay. So what are we looking for? Breast cancer at early ages. So usually, again, before the age of 45 or 50. We're looking for multiple women on the same side of the family with breast cancer. We're looking for even one case of ovarian cancer in a family with breast cancer. I said about 5 to 10% of breast cancers are due to a genetic cause. Newer research is showing that for ovarian cancer, that number might be as high as 20 to 25%. So now, no matter what the family history looks like, if a woman has an invasive ovarian cancer, we actually recommend genetic testing for this condition, because it looks like so many of those cases may be due to an underlying genetic cause. But certainly in combination with breast cancer, we'd be more suspicious. We look for, again, male breast cancer because that's more rare. Triple negative breast cancer we can see in women that don't have this condition, but we see it even more when they do. And again, this is more common in women with Ashkenazi Jewish ancestry. So that's what we're looking for when we take those family histories. Next slide. So I talked about the tumor suppressor genes again before, and in this specific example, it's BRCA1 and BRCA2 that are the good tumor suppressor genes. But someone that has this condition, one of them's not working as it should. So I can't tell you how many times I've heard a woman say, I developed breast cancer because I have the BRCA gene, when really we all have that gene. The issue is there's a mutation in that person's specific gene that causes it to not work. In advance. So these are the cancer risks related to BRCA1 and 2, and because you guys are familiar with this, it still may be helpful for you to look at, because I can say the research has shown that the cancer risk may not actually be as high for most people that have this condition. If you think back to the first studies that we did, we were testing the most suspicious families that were out there. Those were the first people that came to medical attention and had genetic testing. So when we did studies on those people, we said the risk of breast cancer in people with this condition is 80-85% at highest in their lifetime. Now when we average all the families we know about and look at the newest studies, the risk of breast cancer is probably between 50-60% at highest, but that is still so much higher than the average woman's risk of 12%. We also know that women with this condition are at increased risk for a second breast cancer. So not the struggle of wondering, will this breast cancer come back, or will I successfully go through treatment for this breast cancer, but being at least a 40% risk for a second breast cancer. So that obviously is going to make a difference in somebody's treatment plan. And when they get through treatment and they're starting to graduate to perhaps eventually typical follow-up, if you have this condition, we always want to follow you more closely, because we want to make sure that if you're at increased risk for that second breast cancer, we find it much earlier when it's easier to treat than perhaps in the first case. The risk of ovarian cancer is at least up to 44% or so. And at the low end, it's only 20%, but again, so much higher than the average woman's risk of about 1 to 2%, which again is why if we see ovarian cancer in a person, we know it's rare, we know there's a big genetic component to that, so genetic testing is appropriate. This is also important for men in the family. I have women all the time that say, I've already gone through breast cancer, I don't have any kids, or I only have sons, so I really don't think genetic testing is going to be helpful for me. Well, even not thinking about the fact that there could be a second breast cancer or an ovarian cancer, this is important for men too. We can see male breast cancer. And men are less likely to survive because a lot of times they don't think they can get breast cancer. They're embarrassed, they don't go to the doctor until perhaps it's already spread. So it's important for men in the family to know that this can affect them as well if someone has this condition. We can see prostate cancers that are earlier and more aggressive. And in men and women with this condition, we may see pancreatic cancer or melanoma. These aren't core cancers associated. Risk is probably 5% or lower, but it's still important to know about. As far as management, what do we do? So we don't do genetic testing because we're curious. We only do genetic testing if there's something we can do different medically. So if we know someone's at increased risk for cancer, we either want to find that cancer earlier when it's easier to treat, or perhaps reduce the risk for that cancer happening altogether. So from a breast standpoint, if I'm talking to a woman that's tested positive, has a BRCA mutation, has never had cancer, we say from a breast standpoint, we want to either find the cancer earlier, so that means starting mammograms and breast MRIs much earlier, and doing 2 breast exams a year instead of 1. Or we could do a preventive mastectomy with or without reconstruction. That's going to reduce the risk of breast cancer by upwards of 90%. That's obviously a very personal choice to make. It's a big choice to make. We do know that we see women do equally well long term if they do breast surveillance or surgery, so we never want anyone to feel pressured to do surgery. But it's also something we want to make sure that people talk to their families about, talk to specialists, because it is such a big decision to make, and we don't want people to feel rushed. From an ovarian standpoint, I really wish I could say we have great options. We don't. Ovarian cancer is a very hard cancer to diagnose, and it's a very hard cancer to treat. So if we know someone has this condition, we recommend that they have their ovaries and fallopian tubes removed, either as they approach the age of about 35 or 40, or if they're still having kids at that time, when they're done having children. That's of course going to reduce the risk of ovarian cancer, and if that's done before menopause, it's going to reduce the risk of breast cancer by upwards of 50%, up to 50%. When women are younger, we can do things like birth control pills. We've seen that those reduce the risk of ovarian cancer. So there are some options when women are younger. We can try transvaginal ultrasounds and a blood test called a CA-125 that sometimes comes back elevated when someone has ovarian cancer. We do that really to make ourselves feel better, to feel like we're doing something. But no study has ever shown that those two things, even in combination, make a difference in survival. So a lot of work needs to be done in trying to find ovarian cancer earlier. A lot of research is being done, but until a time where we feel confident that we can detect it early and perhaps actually modify somebody's survival likelihood, we just have to recommend the surgery. And we have really good individuals at UAB and other centers in the community that can help someone make that choice. And then annual skin and eye exams for melanoma. Even though it's not a huge risk, it's something that is much easier to detect those cancers earlier when they're easier to treat. So again, this is another section I used to not go into much, but people just seem to find it fascinating. Most of you have heard of hereditary breast and ovarian cancer. That's not the only genetic condition that increases the risk of breast cancer. So sometimes someone's had testing, they say, okay, I had BRCA testing, that was negative, I'm good. There's no way there's something genetic going on, I move on with my life. But really there are other conditions out there. And so it's important to think about seeing someone like a genetic counselor that can tease out a family history and see if there's anything else that we should be suspicious of. Cowden syndrome is one that I'll go into. So with that, main cancers we see are breast cancer, uterine cancer, kidney cancer, colon cancer. It's important because there's also some clues in this condition that aren't cancer. Larger than average head circumference. My patients laugh all the time because every patient I see at UAB, I have the nurse measure their head circumference. And they're like, what in the world? I haven't had my head measured since I was a child. Am I going to get a hat for coming to this visit? So we really just know that almost all the time, if someone has this condition, Cowden syndrome, they have an enlarged head circumference. So that's a clue. That has nothing to do with cancer. We can also see things like thyroid lesions or goiter in these families. We can see lots and lots of colon polyps, so not cancer, but polyps. We can see really characteristic skin findings, so sometimes we might send somebody to a dermatologist, because if I show pictures like this, they're like, well, I've got lumps or bumps, and we'd be there all day. So all of this in combination can tell us that, you know what, maybe BRCA testing wasn't the most appropriate, maybe there's another condition that we should be thinking about. Just like with hereditary breast and ovarian cancer, it's due to a tumor suppressor gene not working like it should. It's just a different gene. It's called the PTEN gene. Next slide. So cancer risks in this condition. The risk for breast cancer is very comparable to BRCA 1 and 2. Some studies put the risk at around 50%, others say it may be as high as 80-85%. We can see male breast cancer, we're not sure what the risk is. Thyroid cancer, uterine cancer, kidney cancer are all up to around the 30% range, and that's higher than we used to think it was. So it's really, even the medical management guidelines have changed over the last few years. And we can also see, again, colon cancer and melanoma. This is a condition we will even test children for, because we can see some of these thyroid problems younger. There can be issues with autism and developmental delay. So while we wouldn't test a child for hereditary breast and ovarian cancer, this is something that could actually impact someone's children and grandchildren at much younger ages. Next slide. So I hope that you guys can see this okay. This is a family that I saw at UAB. So the arrow points to the patient, 29-year-old male. He had pretty significant intellectual disabilities. He had macrocephaly, which is a larger than average head circumference, tons and tons of polyps. His physician said his upper GI and lower GI tract were just carpeted with polyps. His mom had breast cancer at 50. His mom's sister had breast cancer at 45. And then he had a cousin that had lots and lots of polyps like he did. So they came in to see me and they said, you know what, I don't know why we're here. My family has had so much genetic testing. This is such a waste of time. We can never find parking. I just don't know why someone is making us do this again. So I said, well, let's just look at the family history and make sure nothing's missed, because I get 45 minutes or an hour. I'm going to go all the way back to your grandparents and beyond, and you probably didn't have time to go through that much family history with anyone else. So we went through it, we got this history, and I found, and I'm not sure if it's going to work with this advancing, but the mother's sister had been tested for BRCA 1 and 2. That's pretty appropriate. She had breast cancer at 45. That testing was normal. The cousin that had lots and lots of polyps had been tested for the genetic condition that is most common and causes colon polyps. That testing was negative. But no one looked at the whole family and said, what condition can put together breast cancer and polyps and this intellectual disability? It's rare. So if you're not in genetics, it probably isn't even on your radar. But that was the explanation in this family. So we then knew what caused the breast cancer. We then knew the other cancers this family was at risk for, so we could take care of them better. And it also meant that we could test family members, and if they didn't have it, they didn't need anything extra. They would know they're at average risk for cancer. So for this family, we were able to find an explanation by going into more detail and taking a bigger family history, and being nerdy enough to know that there's this other rare stuff out there. Li-Fraumeni is another really important one, especially in this group. So this is an even rarer genetic condition, and it causes especially early breast cancer. So there's a recommendation that if a woman has breast cancer before age 35 and she does not have a BRCA mutation, the National Comprehensive Cancer Network recommends that this testing be considered, no matter what the family history looks like. Because again, we see breast cancers commonly in this condition in people's 20s. So other cancers we can see are sarcomas, which are tumors usually of bone or soft tissue. We can see brain tumors, we can see adrenocortical tumors. The sad thing with this condition is you can see pretty much any cancer, and we see it even in childhood. This is a very striking condition. So the risk of cancer with this condition is at least 50% by age 30. In someone's lifetime, the risk of cancer is virtually 100% if they're women because of the risk of breast cancer. And it's not uncommon to see people get second and third cancers. So as you can imagine, if we take a family history with this, we usually see more. But an interesting thing about this condition is the de novo rate is also high. De novo just means brand new. So with something like hereditary breast and ovarian cancer, we usually see that it's been passed from one generation to the next generation to the next generation. With this condition, it's not unusual to see it be brand new in a person for the first time. So that would explain why we don't see a family history. They're the first person to have it. So if I have a woman that has breast cancer at 25 and no family history, I'm pretty suspicious of this actually. And it's important because people with this condition, again, it's a tumor suppressor gene, just a different one, TP53, they're very sensitive to radiation. So if a woman has this condition, we don't want her to have radiation as part of her treatment plan unless absolutely necessary, because it would actually increase the risk of other cancers. So sometimes it's very important to have this information before someone even comes up with a treatment plan. So when I hear about a young woman at UAB with breast cancer, I quickly try to get her into my clinic to get this testing done before she starts making treatment decisions. Next slide. And this is just a family that had that condition. So my patient had breast cancer at 32. Later, she had BRCA testing. It was normal. She then developed a colon cancer at age 50. So that's when they said, maybe something else is going on here and she needs to see genetics. I sadly learned that she had a son that died of a brain tumor when he was 4, that her father died of a brain tumor, and that she had a nephew that was diagnosed with leukemia about 6 years prior. So we did genetic testing. We found that she did have Li-Fraumeni syndrome. We imagined her son that passed away had the same thing. But then we knew what was running in this family. We were able to offer testing and start following individuals that had it much more closely. And again, the people that didn't have it, we were able to say, I know your family history is really scary. You actually don't have this genetic condition. And sometimes patients actually have a hard time dealing with that. If you grow up in a family where everyone develops breast cancer, they say, I don't care what my doctor says, I'm getting a mastectomy when I turn 30. Or I'm getting breast MRIs 5 times a year if they'll let me have them. But then when I tell them, actually, you don't have the genetic condition running in the family, that's really difficult for them to deal with. Because as you guys know, this cancer can almost become part of a family's identity. And so people struggle to say, wait, so the women in my family, we all develop breast cancer, that's just what happens. It's almost like a club, but we know how to handle it. And then when someone finds out they're not in the club, on the one hand, it's a relief, but on the other hand, they kind of don't know what to do with that. So that's something we also have to talk about in genetic counseling. Next slide. I just want to touch on a couple other ones very briefly. Hereditary diffuse gastric cancer, we see lobular breast cancer. As many of you know, ductal breast cancer is a lot more common, but lobular breast cancer and a very specific type of stomach cancer in those families. So aggressive, we actually have to recommend people have their stomachs removed, even if they haven't developed cancer. And another condition we can see, colon, stomach, pancreatic, breast, ovarian, polyps, and people get purplish freckling around their lips and other areas. So that's something we can look for on physical exam. Next slide. So the reason I introduced a few different conditions is to tell you why, how genetic testing has changed and how we're really in a good time from a patient perspective as far as testing is concerned. Next slide. All of the genes on that slide are good tumor suppressor genes. I think on this specific example, there's 21 different genes. So again, imagine if you were diagnosed with breast cancer, some of you might have been in this boat, got BRCA testing a few years ago, and then I said, if I saw you today, I'd actually offer you testing for 19 more genes if BRCA testing was normal. That's how fast things are changing. Who knows how many genes we could offer you even in the years to come. But it's important to know that we don't have as much information about some of these than others. There are pros and cons of this testing, and it's not something everybody should just run and sign up for. Just to give you an example, the genes in that high-risk category, the pink category, those are all associated with genes we talked about today, the conditions that we touched on. Those are conditions we know a lot about. Those are conditions we know what the cancers are. We have management plans, sometimes on a national level. We know what the cancer risks are, not even just what cancer you're at risk for, but what's the exact level of risk. So we can give people a lot of information. When they're getting genetic testing, they know if they test positive, we're going to have a concrete plan. Genes in that moderate risk category, we've only been offering testing for in the last few years. We've got a lot of big studies on them. We can make customized plans, but we don't have any national guidelines for those. And then genes in the newest category, we've only been testing for the last 1 or 2 years. So we might be able to say, we think you're at increased risk based on this, but there may be other cancers associated too. So when I have patients come back positive for that, I say, call me back every couple years, because we're still learning and I want to make sure I keep you in the loop in case there's anything else we need to do. As you can imagine, some people come in and they say, I want testing for everything that's out there. Test me for all of it. I don't care if we're still learning. We'll figure it out together. I want it all. A lot of people get diagnosed with cancer and they become information seekers like they never knew they could be. They're up till 2 in the morning Googling. I tell my patients sometimes, stop Googling. Oh no, I see people glaring at each other. But again, it's great to get information. But on the other hand, I have patients that say, I came in here thinking if I can get tested for 21 genes, I want testing for 21 genes. But now you're telling me we could find something in a gene we don't know that much about. I could find something in a gene, we don't have national management guidelines yet, so you're going to have to just make a customized plan for me. I don't know if I'm ready for that. I think maybe I just want testing for the genes we know a lot about, and maybe I'll touch back with you in a few years. So that's the benefit of genetic counseling, is sometimes more information sounds like the perfect answer, but it's important to think about the limitations and the cons too. Next slide. This just goes over some other pros and cons of panels. So again, a big panel like that's going to get you as much information as possible. Not every family's textbook. Maybe a family's pretty small, so that's why we haven't seen some other cancers. So in a non-textbook family, maybe a panel like this is better. It helps us determine the cause in a rarer family. So, when we did genetic testing before, I had to say, what am I most suspicious of? Test for that first. If that's normal, do another test. If that's normal, do another test. You think insurance companies were good about that? When I get down to 1, 2, 3 tests? No. And then I'm having to talk with families, is it really worth the money? It may not come back positive. We may be able to follow you just based on family history. It was a challenge. The benefit now is with these big panels, it's one blood test. We're doing it all at the same time. So from an insurance standpoint, it is easier because it's more cost effective. Challenges, it's still more expensive than, say, doing testing for just BRCA1 and 2, especially in a family where that looks like it's probably going to be the most likely thing going on. Again, it may identify a genetic condition in the family we don't know much about, and some people don't want that information just yet. And an inconclusive test result is more likely. I won't go into this too much because that might really put you to sleep, but with any genetic test, there's 3 possible results. Positive means we find a harmful mutation. We know that person's at increased risk for cancer. Negative means we look at all those genes and we don't find anything. So maybe there's not a genetic cause, or maybe we just haven't discovered it yet. And the last is this inconclusive test result. That means we found a difference in a gene, maybe we haven't seen it very many times before. So we just don't know if it's harmful, or maybe it's typical variation because all of our genes are a little different. If we've only been testing a gene for 1 or 2 years, you better believe we're going to find some differences we just haven't seen before. So with a big panel like that, you're more likely to get an inconclusive test result. Some people hear that, and that alone tells them, I'm not sure if I'm ready for that. If someone has an inconclusive test result, we make recommendations based on the family history. So those families still get plans. And the lab may call us back in 6 months or 6 years and say, we kept studying this and now we do know it's harmful. Or now we do know it's just part of someone's ethnic background. If they tell us that, we recontact patients and let them know. So now I just want to talk about what a genetic counseling visit is like, what we do, and so you guys will know what a session entails and whether or not it might be something that's helpful for you or other family members. So essentially, we look at medical and family histories, we educate people about genetic conditions and genetic testing options, and then we counsel them to make informed decisions. Or if they've already had testing, we counsel them about those results and how to see what those results will do about their medical management. Next slide. Again, we don't do testing because we're curious. We only do testing if there's a good test available that will give us helpful medical information, and if that medical information is going to somehow impact someone's management. This is sort of the elements of a genetic counseling session. Some of them we'll go into a little bit more. First thing is contracting, which we'll talk about in a minute. That's just coming up with sort of a mutual plan with a patient. We do a risk assessment by looking at a medical and family history, say which category is this, sporadic, familial, or hereditary cancer, and if we think it's hereditary, which conditions are we thinking it might be. Education, we talk to people a lot about what we went over today, sort of the background genetics, what condition we might be thinking about, what test results are, or what testing is available. Informed consent, this is a big one. A lot of people say, I don't need to sit down with you for 45 minutes, just draw my blood, it's a blood test. My doctor said I was coming for a blood test. This isn't just a simple blood test, there's a lot of implications with these tests. So we want to make sure that we go through everything on the front end with patients so they know exactly what they're getting. Results, like I talked about, not always clear. A lot of people think, well, if I have a negative genetic test result, I'm in the clear. That means everyone in my family is at average risk for cancer. Mine was a fluke. Not necessarily. So it's important that we talk through all that. Medical management recommendations, so as much information as we can give on the front end, but also on the back end, what will this mean for you in the future and what will it mean for your family? And then support. Over and over again today, we're hearing that families need support. Families dealing with cancers, families that have dealt with cancers, families that are terrified that they're going to go through it again. So genetic counseling training actually involves some mental health counseling training as well, so we can provide some psychosocial counseling because we do sit there for 45 minutes with families and go through a 3-generation family history. You can imagine the stories that come up and the stories that come up in the midst of someone's treatment. Next slide. So what do patients usually say they want? If they have cancer, they say, I'm 34 years old, why did I get breast cancer? Or why do all the women in my family get breast cancer? And we have to be honest with them and say, maybe we can help you find that, we may not be able to. So it's also about saying what we can and can't do. They want to know what kind of genetic testing options are available, or maybe what clinical trials are available. They want to know if they haven't had cancer yet, how they can prevent it or find it early. Or if they have one cancer, they want to know the risk for another one. And then as you can imagine, almost every woman or man that sits in my chair and has kids says, I don't even care about myself. I've already had cancer. I want to know what the risk is for my kids. I want to know what the risk is for my siblings. And in genetics, we think about the whole family. So that is something we can at least be reassuring and say, no matter what the test results show today, we're gonna come up with a plan for everybody. Next slide. So risk assessment, the way we do it, we take medical and family history. Some of it's subjective, just saying what do we see, what don't we see, what does our gut tell us about this family. Sometimes we can use different computer models to plug in the family history and say you have this % chance to test positive, because some patients find numbers really helpful. Challenges, limited information. How many of you know about your grandparents or your great-grandparents or exactly what kind of cancer they had? How many families going back that far even talked about cancer? You know, some people kept it a secret. It was something that they went through and they didn't want to talk about it ever again. So sometimes it's really hard to get in-depth information, and that's a challenge. Family structure. If you have a ton of men in a family, well, that's not a lot of breast tissue. Those people don't have ovaries. So that's going to be a challenge to the risk assessment. So you might have a woman like this one who's 47 years old. She had breast cancer, but she said, I have no family history. I don't need genetic testing. Well, she had a brother. Her dad had 2 brothers. His mom died at 25 in a car accident. Who was going to get breast cancer? Who was going to develop ovarian cancer in that family? So we knew then that genetic testing was more appropriate for her, because when we took a family history, we saw that limitation. And then variability. Not every family is textbook, and so we have to keep that in mind as well when we take these histories. What do patients usually bring up as concerns about genetic testing? Cost. I'm in the midst of treatment. I'm already dealing with medical bills. I can't convert any more costs at this point. The good thing is insurance has become much, much better about covering genetic testing. I know at UAB, we only use labs that will check with insurance before they ever begin a test, so that if you don't have coverage, you're not getting some out-of-pocket bill that's a surprise. We also only deal with labs that are really good with working with patients. I can't remember the last time that a patient had to cancel a test because they didn't have coverage, because they either had insurance coverage or the lab worked with them to get it down to a price that they could afford. And now that there's so many genetic testing companies on the market, that's created some competition and prices have come down. Childbearing considerations. So, you know, if we start talking about things like mastectomy or ovary removal, suddenly someone says, wait, I'm 30, I haven't even had my family yet. That can be really scary. So one thing we can say is, you know, you have time to do that. We're going to take all of that into consideration when we're helping you make a plan. But I've unfortunately seen people that had a genetic test through an outside provider, maybe an OBGYN, that said, well, if you test positive, you need to have all your kids by the time you're 30, and automatically I'm going to send you to a surgeon to have bilateral mastectomy and your ovaries removed. Could you imagine how terrifying that would be? Why would she even get genetic testing to begin with? So it's good if we can hear those concerns on the front end when we're doing that contracting and tell them that's not the case. We're going to come up with a plan that lets you do everything you were hoping you could do. Body image and self-esteem, these surgeries are a big deal. I get frustrated when I hear people say, oh, you know what, breast reconstruction options people have these days are great. And I had a patient at Yale that said, I'm so tired of people telling me I'm lucky. They say, I had a bilateral mastectomy, it looks like I have a good prognosis, I got reconstruction with one of the best plastic surgeons, he tells me my results are wonderful, and everyone keeps telling me I'm lucky, and I'm sick of it. Because I don't feel lucky. I developed breast cancer when I was young. When I'm intimate with my husband, I can't feel my breasts. I can't breastfeed my future children. I don't feel lucky at all. I'm so tired of hearing that I am. But I feel guilty for feeling that way because I survived and I know people that didn't. So body image and self-esteem issues are huge, and we want women to be talking about them. We want their doctors and their providers to feel comfortable talking about it. Surgery impact on quality of life. Again, these are big surgeries, so making sure you have that village around you. Management of surgical menopause. A lot of women are terrified about that because, again, they're up to 2 in the morning Googling, and they say, well, if they're going to take my ovaries out, I'm going to go into menopause, but I know that, you know, going on hormone replacement therapy will cause more breast cancer, so I'm stuck between a rock and a hard place. Well, then we can talk about that. If we're removing your ovaries and your breasts, can we do something to find some medication to get you through that? So again, we have whole teams of people that will help people kind of transition through that. And then discrimination. People say, well, if I'm found to have this genetic condition, am I going to be able to get health insurance? Is this going to affect me with my job? And thankfully, we do have legislation in place called the Genetic Information Non-Discrimination Act, or GINA, and health insurance companies and employers can't use this genetic test result. They can't use it against you. And we really weren't seeing discrimination before, but we're still glad that that's in place. Challenges: this doesn't cover life insurance. It doesn't cover supplemental cancer policies or disability policies. So that is something we like to talk to patients ahead of time. We're not seeing those companies ask for genetic testing information, but at this point it's not illegal for them to do so. So I like for people to know about it ahead of time. Next slide. Testing. Again, we'll go through the testing options with patients, informed consent, interpretation, and then we'll call patients back or meet them in person and go through in detail what the results mean for them and their family. Management. For a lot of those conditions, especially in that high-risk category, there are national guidelines. So when they did my introduction, they said I'm on that National Cancer Network panel. We meet once a year, people from cancer centers all over the country, and we say, if someone tests positive, how should we follow these families? What's the latest research? What are people doing? Are there experimental surgeries that are perhaps better? And we all sit there all day long, sometimes for multiple days, and hammer out exactly concrete guidelines, what people should do. But they don't always exist, especially for those rare genetic conditions. So when that happens, we have to use the studies that we have. We have to look at a family history and just say if cancer are diagnosed in people's 30s, we should probably back up screening to 20s in these families. So again, we have to sort of take limitations into account, not only as to whether we know enough about a condition for there to be concrete guidelines, but whether there are even studies out there. And then we take limitations into account. I have families from rural areas that might not have access to some of this. So we have to tweak things and say, okay, if we don't have access to this special pancreatic screening tool, could they do an endoscopic ultrasound? We have to kind of fiddle with that. And then again, support. I think it's great that patients are so involved now in making decisions about their treatment, but that is so overwhelming. If you had cancer 20 or 30 years ago, they'd say, this is what cancer you have, this is the treatment you're going to have, do you have any questions? Now it's, this is the cancer you have, these are all the different options you have, what do you want to do? And that's a lot of responsibility. It's good to feel like you're part of your own healthcare team, but you think, what if I make the wrong choice? They're telling me it's a 5% chance here, a 7% chance here, all these different quality of life concerns, that's a lot of pressure. And now on top of it, I'm asking someone to choose, do you want genetic testing that could tell us about you and your family? Do you want genetic testing for 2 genes, or do you want genetic testing for 20 genes? Do you want genetic testing only for things we have guidelines for, or do you want genetic testing that we're going to have to learn about together? So we're asking patients to make a lot of choices. So it's important to support them through that. We, again, identify what's most important to the patient, sometimes before they even know it, just by listening to them and seeing, and I hear over and over again that they just say, I just want to reduce my risk as much as possible, but I don't know what to do. Well, then I can say, it sounds like if you want as much information as possible and only things you're going to act on to reduce your risk, maybe you just want those high-risk genes or whatever. Again, psychosocial counseling is part of our training, and then we provide support and resources. So I offer as much as I can, but at the end of that, I might recognize that there are some needs there that go beyond my scope. So making mental health referrals, sending someone over to a plastic surgeon to discuss reconstructive options, sending someone to a child health specialist. And then next slide, I think that should be it. Take-home message, only 5 to 10% of breast cancers are due to an underlying genetic condition. We talked about it for 40 minutes, but it's actually a very small piece of the pie. However, there's 20 to 30% of breast cancers where genetics is playing some role. So even if there isn't a positive genetic test, those families may benefit from meeting with a genetic counselor to, 1, just rule out that it's not genetic, and 2, to come up with a customized management plan, because women in that family may still qualify for increased surveillance, either at an earlier age or with things like MRI in combination with mammogram. And then again, the genetic counselor is going to look at medical and family history, see if we're suspicious. What are we suspicious of? What tests can we do? What will we do with those test results? And at the end, come up with a plan and keep your medical team informed of that plan and keep you informed of that plan. I think that's it. Thank you so much for having me.